morning, everyone. Welcome to today's free webinar session. Today, we are going to have a joint session with College of Community Physicians as well as College of Sri Lankan College of Internal Medicine joint session. Today our topic is regarding the malaria. Are we at a malaria epidemic? So before starting the lecture introduction, let me give you a couple of housekeeping messages. So this webinar will be displayed up to 9:50 a.m. as usual, and we cannot allow late attendees afterward. And you will be provided CPD certificate as usual according to NCCPD guidelines. And to improve the standards, we will be conducting the same practice today as usual. And please stick to your our advisors, and please mute your microphones, and please do not hesitate to use any doodling on the screens as well. So hereafter I'll like to introduce both of our lecturers today. The first part of the session will be done by Dr. Pubudu Chulasiri, and the second part will be done by Dr. Chamara Dalugama. Dr. Pubudu Chulasiri is a consultant community physician currently working in anti-malaria campaign, and he's in charge of case management, follow-up, and management of drugs. He has a wide variety of experience in the public health sector, more than 15 years of experience as a MOH, as a senior lecturer, as an expert in dengue control and malaria control campaign. He has done a research fellowship at Department of Health Science, University of York in the United Kingdom, and he has brief experience as a lecturer as well. So without further ado, we are going to introduce our second speaker. He is a consultant physician at Teaching Hospital Peradeniya, Dr. Chamara Dalugama. He's not a stranger for our audience because he has done a lecture with us before. Dr. Chamara Dalugama has variety of experience in infectious disease, and he's one of his interest also infectious diseases, and he has overseas and Sri Lankan publication as well regarding these topics. So I would like to invite Dr. Pubudu Chulasiri to start the first part of our session. Right. Dr. Pubudu, session is over to you now.
Thank you very much, Himal, and thank you, GMOA, and Sri for giving me this opportunity to briefly introduce and explain the current condition of malaria at Sri Lanka now. So, yeah, are we at another malaria epidemic? So, first of all, we have to know whether we are now, as you may be knowing that the malaria is no more in Sri Lanka. But why are we calling that? Are we at another malaria epidemic? So before going to the current situation, I would like to briefly explain how we suffered from the epidemics in the past, and also how we eliminate malaria, because this is very important you to understand the situation that we experience and what are the strategies that we use to control and eliminate malaria. So this is a graph, but it clearly gives the history since 1911. Actually, we had malaria since even in civilization, Poronaru and our civilization, but we have data since 1911. So you can see that we had a huge outbreak in 1934-35 era, and around 6 million, 5.5 million cases had malaria, and almost 82,000 deaths occurred. Huge, the highest maternal mortality rate and infant mortality rate recorded in this epidemic. But government could achieve some kind of control, and the number of cases declined rapidly. But in 1950s, 40, end of 40s, government introduced the DDT spraying as vector control method, and the cases reduced drastically. And in 1960s, 1963, actually Sri Lanka reached near elimination status, and WHO also wanted to declare Sri Lanka as a malaria-eliminated country in 1963. But government did major mistakes, like cutting the funding and reallocate the staff. And because of that, again, in 1967-68, we had malaria outbreaks again. And we suffered around 40 years then, because in 1967, we suffered until 2012, and there were huge number of cases in some times in end of 1980s and beginning of the 1990s. There were huge outbreaks occurred in Sri Lanka. But we had several technical and financial inputs from several organizations, and with the effort from the health sector, especially the health sector in the government sector, we could achieve the 0 deaths in 2007, and 07 in 2007, and last 23 cases, indigenous cases. The cases came from Sri Lanka. Sri Lanka. So 2012, we got last 23 cases. So after 2012, we don't have any indigenous cases so far. So you can see that, yeah, last death occurred in 2007, and 2012 we had the last 23 cases. So since 2012 we don't get any malaria cases. This is indigenous cases. I will later I will briefly tell what is this indigenous cases. So usually a country has to wait for 3 years, consecutive 3 years with 0 cases, and similar, Sri Lanka also had to wait that, and in 2016, we got WHO certification as a malaria-free country. Only Sri Lanka and Maldives, not other countries. India, in Southeast Asian region, not India, not Thailand, no, not Indonesia, not even Singapore, got this WHO certification as a malaria-free country. Only Maldives and Sri Lanka got this certification. It's a huge public health achievement. This is the only disease which we could eliminate from Sri Lanka without vaccination. All the diseases which were eliminated from Sri Lanka was due to the vaccination. This is the only disease that we could achieve without vaccination. But are we having a risk? So why I am talking about malaria? Now I say that, okay, malaria is no more there, no indigenous cases. Do we have risk to have again? Yes. Why? Here, if you see this world map, yes, Sri Lanka is certified malaria free after 2000. But from above to above the equator and the below the equator, there are several countries, especially the countries in Africa, almost all the countries in African region, African continent, South American continent, and Southeast Asian region. Only Sri Lanka is this green color. All the other countries are either dark red. So Sri Lanka, there is a huge migration from Sri Lanka to these countries for several reasons. One is the people, especially the tri-forces, Army, Navy, and Air Force, they go to this peacekeeping mission in South Sudan, Mali, West African region. And there are several gem business people going to the Madagascar, Mozambique, and Kenya. And there are several government sectors established in those countries where our people work there. So from Sri Lanka, lots of people go to those countries. And also from these countries, especially for labor, especially for tourism, especially for as asylum seekers, refugees, people come to Sri Lanka. So in each year, each day there is a huge migration from Sri Lanka to these countries and to Sri Lanka from these countries. So the elimination means we have eliminated only the malaria parasite inside our body, but still we have the malaria vector, which is mosquito, which is who is responsible to spread the parasite from one person, the malaria patient, to another person, healthy person. So we only we could achieve the elimination of yes, as the mosquito is there, at any time there is a huge chance of spreading the disease from this patient to another people. So that's why I said that yes, we eliminated, but still there is a huge risk of getting spreading the malaria in Sri Lanka due to this migration. So if I talk about the world situation, so around more than 75 cases are being reported in African region and then India. And not only cases, also the deaths, yes, uh, huge percentage, around 30% deaths occur in the D pie chart. Yeah, 30% uh, happened in Nigeria and the Congo and the Tanzania, Mozambique, and mostly from India. So huge mortality and morbidity still occur in the world. Yes, we eliminated malaria and we are having no more cases since 2012. But still, as I said earlier, still we are getting imported cases from these countries. Imported mean they go there and they get the malaria parasite inside their body, and with that parasite they come to Sri Lanka and present them as malaria patients. So even in before elimination, we had imported cases, and even after 2012, you can see that in 2013 95, 2015 36, around 40 to 50 cases are being reported in each year as malaria patient, even though you have not heard these cases. So even 2020, we got 31 cases. Because of the COVID, there was a restriction of migration. So in 2020, only 31 cases, and 21, only 26 cases. But up to 4th of May 2022, this year, so far we have got 16 cases as imported cases. There is some kind of difference between these cases and the previous cases. So because usually these imported cases are being reported from Western province, Southern province, and usually the central province, where the vector are not abundant. So we get the patient, we treat them, but there is a little chance of spreading the malaria parasite from these people to other healthy people, as they are the mosquito vector are not there. But here, the now in this 16 patients, lots of patients reported from Jaffna, Mena, and Anuradhapura. That means in those areas there are there are lots of vectors who are responsible for spreading the malaria are there. So whenever patient get a presents as a malaria patient, there is a huge risk of spreading the disease from these patients to the others. So that is the risk of having patients from those areas. So here, as I said earlier, in 2020, out of 30 malaria patients, yeah, lots of patients were reported from African countries, and 4 from India and 2 from Pakistan. And I will tell you what the life cycle and the what are these parasites. but there are 4 parasites, usually Plasmodium vivax, falciparum, Plasmodium ovale, and Plasmodium malariae. And sometimes people come with the mixed infection, 2 or more parasites inside their body. So in 2020, yeah, most of the patients had Plasmodium vivax and then Plasmodium falciparum. But in 2021, it has changed drastically because most of the patients reported as Plasmodium falciparum and then Plasmodium ovale. So that means in 20 after the COVID, lots of people the migration to India because earlier lots of people from India reported as they went to like we call Damadiya Vandana. They went to these pilgrimages and they got the malaria parasite. But as it has stopped. Now most of the patients are being reported from African countries. So risk groups, yeah, risk groups mean these are the people who are at risk of getting disease, the malaria parasite from these countries. So triforces, yes, and gem traders, migrant workers, pilgrims to India and Myanmar, tourists who travel to malaria endemic countries and returnees from South India. Those are the Sri Lankans who go there and get the disease. Or foreigners, foreign laborers, migrant workers, usually the asylum seekers and tourists, they bring the parasite to Sri Lanka inside their body. So these are the groups we have to be more specific. We have to concentrate more on when we treat, when we diagnose, and we especially when we take the history from these patients. Because when we take the history from these patients on their, usually we have to get their travel history. So sometimes you may be thinking, what are the countries that we have to worry? So because there are some countries now, the malaria has been eliminated, but especially, yeah, as I said, most of the African countries and in Southeast Asian region also, Thailand and Indonesia and Laos and yeah, those are the countries. Philippines, yeah, these are the countries also. Malaria is highly prevalent. So and South American countries like Mexico, those countries also we have to be worried, and even Malaysia. Yes. So, what are the factors that we have to think when we talk about malaria? Yeah, this is a triad. Triad means to have the disease malaria. Human is there as the host, and the parasite is there as the agent and the environment. That is the triad. So, other than that, as it is a vector-borne disease, the vector is also responsible for the spreading of disease. Usually, the environment being a tropical country, high humidity, and also the high temperature, and also presence of breeding places, especially the large water pools, especially tanks, the streams, those are responsible as the environment for the spreading of mostly the vectors. So if we break some part of this triad, especially the human parasite linkage or the environment parasite linkage or the environment human, or else human to vector linkage. So if we break one of these linkage, so we can successfully control the spreading of the malaria. Usually what we do is human parasite the linkage. This is the easiest linkage that we can break by having very successful treatment for the malaria. And Dr. Chamara will later will describe what are these drugs and how they are being given to the patients. So as I said earlier, yeah, when we think about this agent, there are usually in Sri Lanka uh, 4 parasites are responsible for the malaria. One is Plasmodium vivax, Plasmodium falciparum, Plasmodium ovale, and Plasmodium malariae. And Plasmodium knowledge, yes, we had only one case, but no more it's there. And also regarding the vector, we call them, there are two types of, not two types, usually the Anopheles are responsible for the malaria, the spreading of malaria, but principal vector, because they have a very high capacity for spreading the disease. So principal vector is Anopheles species, and there are secondary vectors, Anopheles subvectors, Anopheles annularis, Anopheles varune, tessilatus, like those are the secondary vectors. And also for last few years, especially from the Jaffna Peninsula and the Mena and the Vaunia, we had another vector, Anopheles stephensi, you might have heard, because Anopheles stephensi, because principal vectors, Anopheles culispes and others, usually they bred in a very, very large water pools. So, but this Anopheles stephensi, it's like the Aedes aegypti. They need only very small amount of water. And the other issue is that it's very difficult to control by this existing chemical methods, the vector control methods. So presence of Anopheles stephensi is a very, very huge threat to re-emergence of malaria in the, especially in the Jaffna Peninsula and the Mena and Vaunia. So those are the vectors who are responsible for the spreading of the malaria in Sri Lanka. So if we talk about this life cycle, yes, we have to know the life cycle, how the malaria comes to our body and how it is being developed in our body and how we give to the, again to the another mosquito. So whenever Anopheles species bites us, the malaria parasite usually stays inside their salivary glands. So whenever they bite us, they come to our blood. But within half an hour, within 1 hour, usually almost all the parasites go to the liver. Usually they go to the liver and people do not get any symptoms. So they develop in the hypnocytes in the liver and they release their parasite inside into the blood uh, in a time that sometimes it depends on the patient immunity and there are other factors. So usually at least they take around 10 days to uh, uh, release the parasite into the blood, but sometimes they stay inside their liver cells, hepatocyte for about 1 year, especially the Plasmodium vivax and Plasmodium ovale. Sometimes they stay inside the liver for about 1 year and then only they release their parasite into the blood. Until they release the parasite into their blood, they do not get any symptoms. That is one thing. Other thing is there is no any investigation we know to check whether there are parasite inside their liver. So that is the other thing. So the diagnosis is very difficult. Until it comes to the blood, we can't identify that the patient is positive for the malaria. That is the huge issue. It is that's why it's very difficult to control. We have to wait until the parasites comes into the blood. So when the parasite come into the blood, they come into the RBC, red blood cells, and they develop their inside their red blood cells, and they at a certain stage they blast the RBC and again restart their life cycle. So usually when they rupture the RBC, we get these high fever, and other symptoms like chills, rigors, and other things. So usually it takes around 1 week, 5 to 7 days to complete these cycles inside the RBC. Some parasites inside the RBC, they developed into the sexual stage and develop as gametes. So whenever another mosquito, another malaria mosquito bites that person, if the either gametocyte or this the parasite inside the RBC are there, they come into their gut, and they come into their gut, and only the gametocyte penetrate the gut, and then they develop into the again the around 100,000 to 200,000 parasite inside the gut, and then come into the salivary glands. So that is the life cycle. So depending on the stage, our treatment method, our diagnosis, our management varies. So as anti-malaria campaign, these are the functions and responsibilities. Usually we are responsible for the diagnosis and treatment, especially the consultants, the physicians and clinicians are responsible for the diagnosis and treatment, and we guide them, and we usually provide the facilities for them to do these things. Other than that, we do parasitological surveillance, entomological surveillance, and the vector control if needed, and other public awareness programs. So case management, I am not talking about much, but we have proper guidelines. Mainly there are two guidelines, scope of work and treatment guideline. Based in these guidelines, those are available in the anti-malaria campaign website. So you can refer them, because almost all the management we strictly adhere to these treatment guidelines. So these are the scope of work, and this is treatment guidelines. So in these guidelines, it clearly tells when to suspect malaria, how to do the diagnosis, how to do the notification, what are the treatments available, and how the case investigations are being done, and case-based surveillance, and how the follow-up should be done. So those are the things that I want to emphasize, especially from the anti-malaria campaign side, and to give you the brief history and the current status of malaria in Sri Lanka. So Dr. Chamara now will take over this to discuss the management of a patient when we get a malaria patients, and at the latter part we will have a discussion. And okay, thank you.
Yes, thank you, Dr. Pudishulasiri, for your excellent brief explanation regarding the anti-malaria campaign and what we do in the community level. And let me invite Dr. Chamara Dalukama, concerned physician at Provincial Medical Unit in Peradeniya, to do the rest of the session. Dr. Chamara, session is now over to you.
All right, thank you, Himal. Very good morning to you all, and I once again warmly welcome you all for this talk organized by the GMOA. So, and I must first thank Dr. Pupudu for giving an excellent overview about malaria, which made my task much easier. So today talk is about a very important topic, as you understood. So it's rather a question, are we at another malaria epidemic? So I'm going to look at this question from a clinician's perspective. And we must thank the anti-malaria campaign for doing such a wonderful job, because once we suspect malaria, from that point onwards, when it comes to the diagnosis, treatment, case finding, and then further surveillance and further follow-up, all these activities are very well streamlined by the anti-malaria campaign. 20 minutes or so is mainly when to suspect malaria in the clinical context, right? I will briefly discuss about the management and the follow-up, but I think rather than discussing advanced pharmacodynamics or pharmacokinetics of antimalarials, I think the take-home message from the next 20 minutes should be, when you see a patient, whether you have to think, could this be malaria or not? Right? So for this discussion, what I'm going to do is I'm going to take you through a couple of, I would say, very authentic case scenarios that we have experienced, and to see what went wrong and why was there such a delay in the diagnosis. Right. So let me take you to the first case. Right. So this, the case scenario 1 is of a 71-year-old male. He's from one of the rural villages in Kandy, was previously apparently well, and he had fever for 6 days. He had arthralgia, myalgia, shortness of breath with a non-productive cough. And he has seen a GP, and the GP has thought, okay, this could be likely a chest infection. So he has prescribed a cocktail of coamoxiclav, azithromycin, cetirizine, panadine, and dexamethasone. But the patient did not feel better, and he was having persistent symptoms with high fever. And then he was admitted to the hospital. So on admission to the hospital, patient was ill. He was a bit dehydrated, but neither pale nor icteric, no lymph nodes, no skin rashes, and hemodynamically he was stable. And the cardiovascular and respiratory system examinations were also normal. And then the basic blood investigations arranged in the ward showed a white count of 8.24, a hemoglobin of 10.9, a mild anemia, and the platelet count was 167. The coagulation profile was normal. The patient had raised AST and ALT. They were in hundreds. AST was 129, ALT was 79. Mild rise in bilirubin, but not to a level which can clinically manifest as jaundice. Patient had a serum creatinine of 126, normal electrolytes, a slight rise in the CRP, and a normal chest X-ray. So in the ward, the working diagnosis was, okay, likely this could be a viral infection with a secondary bacterial chest infection. So patient was asked to complete the azithromycin started by the GP and was started on IV ceftriaxone 1 gram BD, which was continued for 4 days. So during this 4 days period, patient was having high fevers and feeling very poorly. Then we wanted to look, what was the reason why he is not responding. So the patient's story was revisited. Importantly, there was one crucial question which have not been asked at the time of admission, right? So the question was, any recent travel history out of the country? Right. When you ask this question from this patient, the answer was a very proud yes. So this man is from a very rural village. So it has been his dream to go to India on a pilgrimage for long years. So finally, he was able to go to India with a team of 22 members 3 weeks back. And he was describing his journey. He has from Katunayaka to Chennai, and then he traveled on a train to Bodh Gaya, and then he stayed 1 day in, after one day stay in Chennai. And then he described being to Isipatana, Kapilavastu, Kusinara, Agra, and Lumbini in Nepal by bus. So during this journey, the rooms that they stayed had no mosquito nets, and he has not used any mosquito repellents. And the trains that they traveled were open trains, and he was not on chemoprophylaxis against malaria. Right. So malaria antigen was positive on blood. Thick and thin blood smears showed trophocytes and gametocytes of Plasmodium vivax, and a diagnosis of Plasmodium vivax malaria was made. Right, so we have diagnosed the patient, but that is on 5th day of hospital admission and 11th day of suffering of fever. So rather a delayed diagnosis. But if this question had been asked at the time of admission, we might have thought, okay, could this be malaria? And probably could have diagnosed this earlier than this, right? Okay, let me take you to the second case. So the second case is about a 19-year-old university student from France, a white boy. So he was on holiday in Sri Lanka, presented to a private hospital with a 4 days history of high-grade fever and chills. He complained of severe myalgia and headache. So this boy has been in Sri Lanka for 2 weeks, and he was involved in a lot of recreational activities. He was involved in mountain climbing, freshwater bathing, outdoor camping, etc. So on examination, he was very ill-looking, febrile, icteric, and there was tenderness over the right hypochondria. His respiratory and cardiovascular examination were normal. So then the private hospital has done the initial blood workup, which showed a white count of 10, a hemoglobin of 10.2, a thrombocytopenia of platelets of 78,000, normal clotting, and a significant transaminitis. AST, ALT were in 200s and 400s. Bilirubin was 42, and serum creatinine was 146 with normal electrolytes and a normal chest X-ray. So if you look at the history, examination, and investigation, there's significant exposure to, there was significant mud contact history, and he was febrile, icteric, and tender in the right hypochondria, and had a thrombocytopenia with a marginally high white count, transaminitis, and AKI. So the working diagnosis was leptospirosis based on exposure, examination, and investigations. So he was started on intravenous ceftriaxone and was managed in the private hospital. But on day 3 of admission, still patient was having fevers with chills. Patient was becoming slightly confused, and there was a hemoglobin drop from 10.2 to 7.3, and platelets dropped from 78,000 to 35,000, and there was a rise in bilirubin, and LDH was in 2,000. So then there was a question, are we missing something? Because leptospirosis usually doesn't behave like this while on treatment. Then he was transferred to TH Peradeniya on day 4, and the history was revisited. It's true, he's from France, and it's a country which does not have malaria. If you remember Dr. Pupudu's map, it was a white area because there's no cases of malaria. But in his travel history, before coming to Sri Lanka, he has visited and stayed in Ghana for 2 weeks. He recalls multiple mosquito bites and has been a lot of doing recreational activities there, lot of outdoor camping nights, etc. And he was on malaria prophylaxis, but he was also not very sure whether he had been compliant throughout. Then on day 4 in Peradeniya, we tested him for malaria. Antigen was positive, thick and thin film showed Plasmodium falciparum with a parasitemia of more than 5%. And his case was complicated with an acute kidney injury, lactic acidosis, anemia, and hypoglycemia. So he was diagnosed with severe falciparum malaria. So both these cases were diagnosed and treated, and they walked home. So there was no sequelae. But the important thing is there was a significant delay in diagnosis. So once we have suspected, could this be malaria, the anti-malaria, the regional malaria office, the anti-malaria campaign, they get alerted and they come to see the patient, they issue the drugs, they arrange daily blood films, and then they issue the drugs, and then finally they arrange the long-term follow-up for this patient as well. And then they carry out the surveillance activities. So as I mentioned to you before, the bottleneck in these 2 cases were the clinical suspicion from the primary healthcare doctors, or basically the first encounter doctors, right? So this is, I won't say acceptable, but this is the reason. As you know, from 2012, the malaria has been eliminated from Sri Lanka. We got the certificate. So there is a very low disease burden. So nowadays, doctors hardly see a patient with malaria. So the clinical suspicion is very low. So when you have a low clinical suspicion, that leads to significant delay in the diagnosis, and which can lead to uncomplicated malaria, complicating into a severe malaria, right? And mind you, we have the Anopheles mosquito in the country, so there can be, inside the country, there can be transmission if there is a significant delay in diagnosing the malaria, right? Right, okay, let's go to this side. And if you remember everything, if you forget everything in this lecture, but if you take this message home, I think that is more than adequate. That is, when to suspect malaria in clinical context. So always you have to ask yourself, could this be malaria whenever you see any patient with fever, right? So any patient with fever, the crucial question that you need to ask is whether they had been recent travel history out of the country, right? So this word recent is not like weeks or months, it is within 1 year. Sometimes your patient might tell, if you ask Have you been to some other country recently? He might think, okay, I have not been outside for last few months. So answer would be no. So you have to specifically ask, for last 1 year, have you traveled out of the country, particularly to malaria endemic areas? And these high-risk groups include the businessmen, the pilgrims, seamen, resettled communities, refugees, and asylum seekers, right? So at least this point, any fever patient always ask about the travel history, and that is where we are lacking. Then if you suspect malaria, then everything else afterwards is nicely streamlined. And the second one is any individual presenting with clinical features of severe malaria. So in the next slide, I will discuss what are the clinical features. So we will discuss that during that slide. And the third one is anemia of unknown cause, right? Sometimes you may be investigating a patient for a chronic hemolytic anemia. Anemia and basic investigations normal. There is anemia, there's a bit of a thrombocytopenia, high LDH, indirect bilirubin fraction may be high. So we have to stop and think, could this be malaria, right? And any patient with organomegaly, hepatosplenomegaly, you have to think whether this could be malaria. And any patient who received blood or blood products within last 3 months developing fever, you need to think about malaria, right? So always when you encounter in your clinical practice, these 5 instances, any febrile patient, any patient with features of severe malaria, any patient you are investigating for anemia, any patient you find the hepatosplenomegaly, or a patient with a recent blood transfusion coming with fever, you need to suspect malaria. And this is again an important message that we always think that malaria is always high fever with chills. It's not the case. Fever is not a universal finding in malaria. Sometimes you might find a patient with chronic anemia or organomegaly without fever who has malaria. And the other important thing is, for last few years, the thrombocytopenia is a common lab investigation that you find in malaria patients. So fever with thrombocytopenia in our context, we think, okay, could this be dengue? Could this be leptospirosis? Could this be rickettsial infection? But in your differential diagnosis, keep malaria at the bottom and think about malaria as well. Right. So this slide will tell about the features of severe malaria. So any patient coming with impaired consciousness and prostration. Prostration, the word means is that the patient is too weak that he can't get up or he can't walk without any support. And patients with multiple convulsions, patients with acidotic breathing, pulmonary edema, circulatory collapse, acute kidney injury, and jaundice and abnormal bleeding. So these patients, these clinical features are considered as features of severe malaria. And then laboratory-wise, low sugars, metabolic acidosis, low hemoglobin, high lactate levels, renal impairment, and pulmonary edema, right? So if you diagnose malaria and if they have these clinical features, you call it severe malaria. But in the other way around, if you get a patient who is unconscious, right? Patient may not be able to give a history, but it's important. A patient who has multiple fits and coming unconscious, he has low sugars, severe lactic acidosis, try to get a collateral history, try to talk to the family and try to get the history whether he has had a recent overseas travel and then screen for malaria, right? Okay, so I'm not going to talk in detail about diagnosis because this is again very well organized, arranged in the country. So if you talk to your public health field officer or the PHI in your hospital, or if you talk to your regional malaria office, they will be more than happy to help with your diagnosis. So it is mainly by microscopic examination of blood smears and by doing rapid diagnostic tests. Right. So how do you treat malaria? Again, I think this I don't have to emphasize a lot because there are already very well written guidelines and there's enough support in the community, in the regional malaria office, in the malaria headquarters, for how to treat, and they will be there with you when you are treating a case of malaria. So I'm just briefly outline the management. So a mono infection with Plasmodium vivax, we treat with chloroquine, and to eradicate, to prevent relapses, we treat them with primaquine as well. An uncomplicated Plasmodium falciparum, we use artemisinin-based combination therapy, what we call coartem or ACT. And in infants and children, we can use the same coartem, but in pregnancy, in pregnant patients with falciparum, in the first trimester, we tend to give them quinine, with or without clindamycin, but from the second and third trimester onwards, we can try Coartem. But primaquine is contraindicated in pregnant patients and those with those who are lactating, particularly in mixed infections, where we need to treat the relapses. And then in mixed infections, we have to treat with Coartem as well as primaquine. And severe falciparum malaria, we use intravenous artesunate or intravenous quinine. Right. So severe malaria, it's a medical emergency, right? So the patient will usually need an ICU care or a high dependency care management. They will need very close monitoring with regard to their vital signs, the coma score, and the urine output. And the drug we use is IV quinine. And when you are using IV quinine, one thing is it can make your insulin levels to go up and you can become hypoglycemic. So blood sugars need to be closely monitored. And the other thing is quinine can have a lot of effects on the cardiac conduction. So QT prolongation and arrhythmias. So while the patient is on quinine, you need close cardiac monitoring. Right. So what are the practice points when you are managing a patient with malaria? Because most of the time the advice and the guidance is from the anti-malaria campaign, and it is mandatory to treat all malaria patients as inward patients for minimum of 3 days, right? And then this patient should be managed under a mosquito net until the parasitemia clears. And thirdly, we use primaquine, particularly in Plasmodium vivax and Plasmodium falciparum and vivax mixed infections, to kill the hypnocytes and to treat or to prevent relapses. But we need to test for G6PD deficiency if the facilities are available prior to administration of primaquine as anti-relapse therapy. Right. And this is again one of the very important things that we need to do. It's not only diagnose, but if you suspect malaria or diagnose malaria, we need to be immediately notified via telephone to the regional malaria officer and anti-malaria campaign headquarters by the doctor who is treating or the lab technician who is seeing the blood film, right? So notification is very important. And also it needs to be notified to the medical officer of health, right? Okay, so let's go to another case. This is the last case. This is a common case probably you have experienced. An elderly couple in their early 70s come to their GP and state that they are planning to visit India on a pilgrimage in 2 weeks' time and ask for a prescription for routine medications and for some analgesics, as they are planning to stay there for 18 days. And other than that, sometimes the patients might come, they might ask for some treatment for, in case if I get diarrhea, doctor, would you give us something? Or if we get cough, would you give us? Likewise, this is a common thing. Before visiting India, these people tend to go to their GP and tell whether, asking for some certain prescriptions. But other than that, is there any advice that you would give for them? Right. That's about chemoprophylaxis, right? So the most appropriate chemoprophylaxis should be decided upon the destination of the patient, where the patient is going to, right? So it depends on the country of travel. So we consider the risk of Plasmodium vivax versus Plasmodium falciparum. Commonly, our people visit India and Nepal, where the risk of vivax is high, so that we give them chemoprophylaxis. And certain people who are going to African countries, sub-Saharan countries, the risk of falciparum is high there. So your chemoprophylaxis depends on whether you are a last-minute traveler, whether it's a planned travel, whether you are going to stay for a longer period, and then whether you have any medical G6PD deficiency or any allergies. So I'm not going to talk in detail about chemoprophylaxis. You can always refer to the guideline or the circular, or you can talk to your regional malaria officer. But particularly in India and Nepal, we give the prophylaxis with chloroquine, which need to be taken before 1 week before the travel and need to be continued. And even 4 weeks after coming back to Sri Lanka. And then for African countries, we use mefloquine as the chemoprophylaxis. And this chemoprophylaxis can be easily arranged through an OPD referral to the public health field office in your hospital, through PHI to the regional malaria office. Right. So this is all what we need to keep Sri Lanka malaria free. Right. This I have taken from one of the circulars in the anti-malaria campaign. It is ABCDEF approach. So aware of the risk of malaria in the country to be visited, yes, you need to ask about that. And we advise the patient to avoid mosquito bites, because just because you are on chloroquine or mefloquine, that won't guarantee that you won't get malaria. So you need to use other protective strategies when you are traveling, and chemoprophylaxis when indicated, we have discussed that. And then when they come back to Sri Lanka, whenever they come with fever, ask about the travel history, suspect malaria, and then screen for malaria. And then early and effective treatment. And finally, if you delay it, if the diagnosis is delayed, that is the bottleneck, as I mentioned. Once you diagnosed, everything is streamlined. So malaria can be a fatal condition. Right. So that brings to the end of my presentation. So once again, the take-home message would be, in the clinical context, if you see a patient with fever, always ask about a travel history and suspect malaria, right? If you suspect malaria and do the relevant notifications, you will not miss a single case of malaria, and there will be no significant diagnostic delays leading to a lot of other complications, right? Thank you very much.
Thank you, Dr. Chamara, for your fascinating talk on malaria management in a case-wise. And as usual, you are not a stranger to us. And I have a couple of take-home. I have a couple of questions for you, our both speakers. So let me start with Dr. Prabhudu. If we miss malaria prophylaxis before travel, what can we do about it?
Yeah, as Dr. Chamara mentioned clearly, we have to start them 1 week before travel. Yeah, as Dr. Chamara mentioned clearly, we have to start the chemoprophylaxis 1 week before they travel to either to the India or to the African countries. So sometimes some people comes only just 1 or 2 days earlier, saying that, okay, I just got, I have to go to these countries, and what can we have? One thing is, yes, chemoprophylaxis are there, the drugs are there, but as Dr. Chamara mentioned, we can't guarantee them that these will give 100% protection. So we have to always prevent from mosquito biting, like wearing long sleeve the shirts and the trousers, and there are some repellents available in the open market, and preferably they have to sleep under a bed net. But if they want some, if they say that those are not practical, other than the chloroquine and the mefloquine, there is another drug, that is doxycycline. So doxycycline can be taken around 1 to 2 days earlier before they travel. So doxycycline, but it's a weekly a daily dose. So for a short travels, like 1 week, or especially for the conferences, so doxycycline is much more preferable than these other drugs. So as you asked that, yes, if they miss it, yes, they still can get the drugs like doxycycline, or else if they come at the last moment, if they are going tomorrow, then also while they are practicing their mosquito bite prevention method, they can start doxycycline, but they have to continue for 4 weeks after they came to Sri Lanka.
Another question came through the audience: how long we have to take these drugs? Sometimes people are staying more than 1 year in some risk countries. So any other advice on top of this?
Yeah, for the chloroquine, yes, it's a very safe drug, but usually for the mefloquine and chloroquine, we usually recommend them to have for 1 year, because there is no evidence of their interaction side effects even after 1 year. So whenever usually some people come to us that saying that they are staying there for about more than 1 year, then what we ask them to get done, because mefloquine, usually the mefloquine, they affect their liver. So we ask them to get done a liver function test. And if a liver function test are the values are within the reference range, but we ask them to continue it for 6 months more. But there are no evidence that more than 6 months their efficacy and other things. So we don't encourage them to have mefloquine more than 1.5 years.
Right. Do we do any community screening of patients for malaria in Sri Lanka?
That's a good question. We do proactive and reactive. Proactive means even though we don't have cases, we have to make sure that there are no people in Sri Lanka with the parasite inside their body. So we randomly go to some places, especially the places that those people who are at risk, the people who came from these African countries, sometimes in factories, in some construction the areas, we do go there and do the testing and make sure that no person no person having parasites inside their body. That is proactive. And also reactive. Whenever we get a case, we do parasitological as well as entomological surveillances to find out that around this home where he stayed for last 14 days, we randomly select people around 1 kilometer radius and do the screening of these people to confirm that there are no parasites inside their body and there are no vectors around these areas, to confirm that the patient has not spread the disease to others.
A lot of questions coming through the line regarding prophylaxis. Can we continue in children in prophylaxis?
Yes, because chloroquine as well as mefloquine also can be given, but for the infants, we don't have any evidence, so we don't usually recommend prophylaxis for the infants. But based on their weight, the body weight, we recommend prophylaxis even for the kids.
You mentioned about doxycycline prophylaxis for short travel. How long we can continue it?
It is same as other thing, as long as they stay there. Because I forgot one thing, mefloquine, there are some contraindication for the mefloquine who are for the people who are going to these African countries. Mefloquine cannot be given to people who are having psychoaffective disease like depression, schizophrenia, and those diseases, and people who are having epilepsy. So mefloquine is contraindicated. So for these people, what we usually recommend is doxycycline. But the issue is mefloquine is a weekly drug. But the doxycycline, it is a daily drug, as well as it gives very unpleasant side effects such as gastritis and other issues, photosensitive rash and other things. So what I recommend is, if you have those kind of contraindication, I recommend mefloquine rather than doxycycline, because the compliance is good. But both drugs we have to continue as long as they stay there in the country, and they have to continue for 4 weeks after they came to Sri Lanka.
This question comes to both our speakers. You may answer. Pregnancy and the chemoprophylaxis for malaria and primaquine.
Dr. Chamara, will you answer that?
Yes. So in pregnancy and in lactating mothers.
Chamara, we can't hear you.
All right. Sorry. Can you hear me now?
Okay.
Hello. Himal, can you hear me?
Yeah, we can hear. Yes, continue.
Yes. So in pregnancy, actually the primaquine, and in lactating mothers, primaquine is contraindicated. So that's a problem. So in pregnant mothers who had this bivax malaria and during the lactation period, we don't use primaquine, but after that we can complete a course of primaquine. And when it comes to the treatment, chloroquine is safe in pregnancy. But when it comes to artemisinin combination therapies, so In first trimester, usually we treat them with quinine and clindamycin. And from the second and third trimester onwards, we can use coartem as a treatment.
Rest of the question actually comes to the Dr. Shamara. Any admission criteria for the malaria? Do we have to admit every patient, as you mentioned, if you diagnose malaria in Sri Lanka?
Yes, I think when you diagnose malaria, the patient definitely need to be treated at least for 3 days as an inward patient. So all malaria patients are treated as inpatients in the first 3 days.
Can I add one more thing for
Yes,
that?
yes.
Dr. Chamara, if you don't mind, other than that, there is no hard and fast rule that they have to get admitted to the government sector only. Even in the private sector, where a physician there, consultant physician there, you can admit to a private sector, any private sector hospital and get treated, but all the drugs are provided free of charge. Even for this private hospital settings also, we provide the anti-malaria drugs and they are provided free of charge.
Yeah, that's a very good message for the audience. The last question, it's coming from the audience actually. What are the commonest blood investigations we see, abnormal blood investigation we see in the malaria? As you mentioned, there's a thrombocytopenia and hemolysis. If you can recapitulate it, Chamara, it will be really helpful.
Yes, so when it comes to the clinically and examination and investigations, malaria can be a great mimicker, right? So we tend to think about all the other possible diseases as we have a low clinical suspicion of malaria. So usually when it comes to blood investigations, the full blood count, you might see a normal white count or sometimes the white count can be high. But there can be an anemia. But again, anemia may not be a universal finding because early stage, patient may be having a hemoglobin of 15, it might have dropped to 13, which again, we don't label it as anemia. In certain patients, there can be a significant drop in hemoglobin. And thrombocytopenia is one of the common findings that we see in the full blood count. And looking at the blood film, looking at the anemia and the low platelet counts, sometimes for routine investigations, we might arrange a blood picture where the hematologist will renew and tell, okay, we are seeing malaria parasites inside the cells. That is one way sometimes the malaria is diagnosed. And then with the liver involvement, there can be elevation of liver enzymes. And then particularly in falciparum malaria, where there is sequestration and obstruction of the microcapillary circulation, there can be tissue level hypoxia, which can lead to elevation of lactate levels. There can be renal impairment, etc., etc. But these are late findings, and we should not wait for that. And in addition to that, because of the ongoing hemolysis, there can be features of a hemolytic anemia. There can be elevated bilirubin, and the indirect fraction will be high. There may be a high retic count, and then there will be high LDH levels in blood, which can tell, okay, there is some active hemolysis going on. And rather than the common causes that we think about, autoimmune causes, drug-induced causes, we need to consider the possibility of malaria as well.
To the finish the session, I would like to hand over Dr. Prabhudu the last questions and answering, and he has some take-home message to deliver you. Dr. Prabhudu, what is the sensitivity of these tests? That mean blood film as well as rapid diagnosis test.
Yeah, because both give same results, but whenever we think about the feasibility, because RDT, rapid diagnostic kits, it gives the results within 20 minutes, and we don't need any experts, especially the public health laboratory technician, to get this done. So especially in the places where those staff are not there, we do the rapid diagnostic test, and it has very good high sensitivity and the high specificity, especially for the Plasmodium falciparum. The sensitivity and specificities are very, very high. So if it gives the results as Plasmodium falciparum, we can confirm that those are positive with Plasmodium falciparum. But our gold standard test is microscopy, thin and thick smear microscopy. Yeah, then it has almost 100 sensitivity. But thing is, if the parasite counts are very, very low, so we need a very high expert, the experienced PHLT, public health laboratory technicians, to get it done. Unless sometimes they will miss these some parasites if they have the counts are very low. But we usually consider the microscopy is the gold standard test.
Thank you. So before wind up session, I would like to thank both colleges who have joined in hand to contribute to today's session. Sri Lankan College of Internal Medicine as well as Ceylon College of Physicians. And today our two resource persons. First, Dr. Pudu Chulasiri, Consultant Committee Physician. Thank you, sir, for your contribution. Dr. Chamara Dalugama, Consultant Physician at Teaching Hospital Peradeniya. Thank you for your contribution, Dr. Chamara. And we would like to continue your support in our future sessions as well. So that will be all for today's sessions. Thank you everyone for joining with us. And we'll be expecting you in next session next Sunday. Thank you.